evening. Welcome to a special presentation of the Lawrence Family JCC Jacobs Family Campus. My name is Ryan Isaac. I am the Director of Cultural Arts at the San Diego Center for Jewish Culture. Thank you all for joining us. It's nice to have everybody in this new webinar capacity. We can't see you like we used to, but we hope this provides a better experience for everybody and for tonight's guest of honor, Dr. Ed Septimus. Tonight, we are very lucky to have Dr. Septimus with us. He has been practicing in the medical field for over 5 decades. He received his medical degree from Baylor College of Medicine in Houston in 1972. He completed his postgraduate training in internal medicine and infectious disease at Baylor College as well. And he's currently the medical director, Infection Prevention and Epidemiology Clinical Services Group at HCA Healthcare System. So thank you for joining us, Dr. Septimus. I also would like to thank, before we turn things over to you, I'd like to thank our underwriters. We've had underwriters for many of our programs and departments. We have just launched the J Company appeal for the 2020-2021 season. Thank you to all who are supporting and who intend to support. The film underwriter appeal will begin soon. After that, we'll have J-Learn, we'll have Arts and Ideas, full virtual seasons for 2020-2021 for everybody. So thank you for being a part of this. Thank you for being with us. And now tonight to discuss living with COVID-19, specifically science over politics and fear, Dr. Ed Septimus. Dr. Septimus, thank you for being with us. How are you doing?
I'm doing fine, Ryan. Thank you very much. I also see Abby down there at the bottom. It's nice to meet you all virtually. Have some roots that, go back to San Diego. It's a great JCC that you have out there. So thank you for the opportunity to have a conversation with your community. I titled this sort of science over fear and politics because, we're a very divisive country right now, and you're watching me rather than watching the Democratic National Convention. So I don't know what that means. But I think it's probably one of the things. I've been at this, as you've heard, over 4 decades. Just to give you an idea, I was a Brooklyn Dodger fan, so that'll tell you how far back I go. But as I was thinking about, I've been through Ebola, I've been through bioterrorism, I've been through the pandemic in 2009, 2010, but nothing quite like this. First of all, in terms of the scope, the fact that it's shut down part of the economy for part of the time, and the fact that the science has evolved so rapidly, and you'll understand that as I go a little further. And it's sort of understandable that what we said back in February and March, I'll highlight masks in a moment, turns out to have changed in April and May when new information became available about this brand new virus that we had not experienced before. But the reason I said science over fear in politics, one of the things that really irks me, I must tell you, is that the news tends to always favor the exception and horrific over what's routine and unremarkable. And it really bothers me, and it makes it extremely difficult for the average public to say, I am afraid to go out of my house. You should respect this virus, but I hope at the end of our discussion, you won't fear it quite as much. The second thing that is really bothersome to me, and I understand that people are on the left and on the right, this is not a left or right issue. This is a public health issue. And it's bothersome to me that some of the news coverage is clearly politically motivated to select use and manipulate the data to damage whichever side you're against. And I'll give you an example. I was making this slide up for a presentation I'm doing next week to a medical group. And it's headlines from August 13th, so it's less than a week ago. The New York Times, the true corona toll in the United States may exceed 200,000. That's a pretty scary headline. Let's go to the Washington Post. U.S. reports highest number of COVID deaths in one day since mid-May. Now we go to the Wall Street Journal. U.S. daily corona case drop to lowest level since early August. This is all on the same day, looking at the same data. Do you want to look at data that gives you a little hope, or do you want to give data to continue to pound the negative that scares the public? And I hope that I can give you a balanced discussion this evening. You'll judge. You've probably all heard about flattening the curve. And the flattening the curve was really originally designed so that we could maintain our healthcare capacity by spreading out the number of cases over a longer period of time, as opposed to, unfortunately, what happened in New York City, what happened in Wuhan, China, what happened in Italy, which of course were terribly stressful. And so the whole idea of having shelter in place, social distancing, and some of what we call the non-pharmaceutical was really to flatten the curve so that our healthcare system could maintain its capacity. Now tonight, I not only want to talk about flattening the curve, I want to also flatten the fear. So how does this particular pandemic kind of stack up to the 1918 Spanish flu? Just to give you an idea of numbers. The Spanish flu killed around 50 million deaths worldwide. And remember, the population of the United States and in the world in 1918 was much, much lower than it is now. In the United States, it killed over 600,000 deaths. And it is true, by the way, that unless we do the right thing, we could reach 200,000 before the end of this year. I hope not. I hope it's going to be considerably less. But as you can see, considering we have over 30 million people in this 300 million people in the United States, think how many people lived in 1918, and think of the devastation of over 600,000 cases during that particular era in 1918. So this gives you some idea about how to judge the numbers. The other thing that we want to talk about, of course, is deaths. So when this pandemic first hit, it was felt that the mortality rate was actually much higher than it's turned out to be. So now the mortality rate, all ages, and of course there are some high-risk populations and some people that are older where the risk is higher, but for all populations, the mortality rate now is around 0.5%. Now that's higher than flu, which is around 0.1 to 0.2%. So I want to put this in proper perspective. Now let's talk about some of the other coronavirus. This particular COVID-19 is a coronavirus officially named SARS-CoV-2. Now, the original SARS was in 2002, 2003. That's called SARS-CoV-1. And the reason it's called SARS-CoV-2 is because they're so genetically similar. And the initial response and guidance about this pandemic came from the experience of the original SARS outbreak in 2002. And I'll describe how different it turns out to be. But that was the best we had in February and March. But look at the mortality rate due to the original SARS, MERS, the Middle Eastern syndrome, which is still ongoing in the Middle East and sometimes comes to the United States, and Ebola. You all remember Ebola. The mortality rate from those viruses is somewhere in the range of 10 to 15%, up to 50%. So just to give that mortality rate in proper perspective. Now, the current COVID-19 virus is a little bit more contagious than the original SARS virus was in 2002, 2003, just to kind of put some of that into perspective. Now, worldwide, as you know, we're over 5 million cases. Deaths in the United States are around 170,000. So you can see we are heading in that direction. I'll come back and talk about children a little bit later. I did look at the data in California and in San Diego, and I'm happy to say, like it is in Houston, by the way, Houston was really a hot zone. Our second wave was much bigger than our first wave and was quite significant. But just like you are in California, we're beginning to see a reduction in cases in the last 2 weeks. And in San Diego, you have a little over 600,000 deaths. You're testing about 5%. That is 5% of all tests are positive for COVID. And you have an actual rate now of being less than 100 cases per 100,000. So you're heading in the right direction, and I hope that continues, as I hope it does across the South, where we've been very, very hard hit by the second wave. Now, the dynamics of this particular virus. So this particular virus has an incubation period between 2 to 3 days up to around 12 days, with a mean incubation period of about 5 days. So that's the time you get exposed to the virus to the time that you may develop symptoms. And one of the things we've learned about this virus, which is very, very different from SARS, so here's one of the big contrasts. We talked about the difference in mortality. The second thing is the original SARS virus, okay? You did not become contagious until after you developed symptoms, and the amount of virus that you were able to transmit got to be at the highest rate after the first week. This particular virus, you shed virus in 2 days before you become ill, and the peak amount of virus is that 1 to 2 days before symptoms, and the first 2 to 3, 4 days of illness, and then it declines actually towards the end of the first week. So very, very different from the original SARS virus. We now also know that a certain percentage of people may be asymptomatic and never develop symptoms. And we think that may be in the range of around 20+%. And then there's another 20+% that we call are pre-symptomatic, meaning they don't have any symptoms yet, but they still may be contagious. But in around 2 or 3 days, they will develop some symptoms that is associated with COVID-19. So because of that asymptomatic period where it can be transmitted to others, that's why the masking policy has changed. So in the beginning, we thought it was like SARS. And if you remember, CDC, World Health Organization, Dr. Fauci, who I know and respect greatly, all said you didn't need to wear a mask unless you had symptoms. We were using the original SARS as our guide. Once we realized that people could shed virus, not have symptoms, and transmit it, that's when we began to implement universal masking. Again, I'll come back and talk about that, but universal masking is one of the most effective ways to reduce transmission in your community. So the mean incubation period is about 5 days. That's why we say that 2 to 12 day realm. So if you get exposed, you've heard people should be quarantined for 14 days because there's a rare person that may take 13+ days to become ill. And so if you get exposed, but you've not been infected, we put you in quarantine for 14 days. So that's where the 14-day issue came up. The next thing is about how contagious this virus. Remember, I told you that influenza is a little bit more contagious than influenza. So we talk about something, you may have read this, called the reproductive number, which basically is the number of secondary cases that occur from the primary case, the index. So the first one to come into that community or into the household that gets infected, how many other people in their sphere can they infect if they're susceptible to this particular virus, which most people are. So for influenza, that reproductive number is about 1.8 in their range, maybe up to 2. This particular one, the reproductive number is about 2.4. So for every 1 case, secondary case is about 2 to 2.5 secondary cases. Now let me compare that to a highly contagious virus that you all know, especially in California, measles. The measles reproductive number is up to 18. Now that is clearly an airborne disease that is highly transmissible. And that's why when your immunization rates drop, that's when you have these outbreaks. Of course, the biggest outbreak that you're familiar, of course, is Disneyland, just north of San Diego. So that just gives you some idea about that. Now, how is this transmitted? Well, we think the primary way in which this is transmitted is what we call by droplets. And you heard of that, that's 6 feet. So most droplets don't go more than about 3 to 6 feet. It doesn't say suspended in the air very long. There probably is an occasional situation, especially in poorly ventilated areas, where you might get a more of an airborne transmission where it may travel more than that 3 to 6 feet, but it's generally in crowded, poorly ventilated spaces. The great thing about San Diego, you've got great open space, and your weather is so much more conducive to outside activities than, let's say, Houston is now, where the temperature's between 95 and 100 degrees every day. So you've got that advantage. There's also it's now considered less important, but inanimate objects, high touch objects that may get contaminated with the virus. So the virus can remain on surfaces for a short period of time. It actually degrades fairly quickly, but it may remain viable. And if the number of virus particles is high enough and you touch an object that somebody else just touched that's contaminated, potentially the virus can be transmitted by inanimate objects. But we think by far and away, the most likely reason for transmission is by droplets. So let me give you an idea in the real world what we mean about contagion. So if household contacts are probably the best way to look at it. So someone comes into the household, it's your mother, your father, older child, they gotten infected in the community, and they come into the household, they're living with you, they don't know they have it yet, but they're shedding virus and they're contagious. What percentage of the household will get infected? Well, it turns out that most household contacts, it's around 10+% in the household. And if you're a spouse or a significant other, so you're living in the same bedroom and you're sharing the same bathroom, that rate may go up to as high as 40%, just to give you an idea. Now, close contact, but perhaps less sustained contact, results in lower transmission. The classic example, I'm sitting around a table at work, none of us are wearing masks, I'm infected but don't know it, and the other people in the room are susceptible. That transmission rate's around 7%, just to give you an idea. And then I want to give you a sort of a sample about how masks are so effective. So there was a recent report from the CDC about 2-3 weeks ago, maybe you heard about this, about 2 hairdressers who happened to have early symptoms of COVID-19 and took care of over 130 clients. Now, we define close contact, someone who's exposed, to be someone who's with someone for 10 to 15 minutes without wearing masks within 6 feet. That's what we consider a close contact. So certainly a hairdresser is certainly within 3 feet, and they're certainly spending more than 15 minutes with their clients. So that's the scenario. This hair salon, though, had very strict policies and required all clients and their hairdressers to wear masks. So while these hairdressers were symptomatic and potentially contagious, they were wearing a mask. The clients were wearing a mask. The transmission in that environment, when studied by the CDC, I'm happy to tell you, was zero. Zero, because they had an effective mitigation policy in place. If I wear a mask, I protect you. If you wear a mask, you protect me. Really, really effective in preventing transmission if you wear a mask. Now, what's the natural history? 80+% of people who get infected with COVID are going to have mild, if any, symptoms at all. Okay? It's another 5+% that may get increasing symptoms, and the top 10% may get enough symptoms that will bring them to the hospital. And of those individuals who go to the hospital, the worst 5% may get critical enough that they may have to go to the intensive care unit, and they may or may not need to be on a respirator. So 80+%, mild to no symptoms at all. The top 10% who have enough symptoms that they require hospitalization. Usually it's because of shortness of breath and they need some supplemental oxygen. And it's only 5% of the total that may actually have to be in the intensive care unit. The timeline is important because when we talk about community, so I get infected on day 0. The incubation period, you remember I told you, was an average of 5 days. Okay, it's going to take another week or so before I may develop symptoms such as shortness of breath that might bring me to a physician or to the hospital. So now you're talking about almost 2 weeks in, and then another 3 to 5 days to be actually in the hospital and potentially in an intensive care unit. So we always have about a 2 to 3 week delay in measuring potentially community spread because of delay from the time of infection to the time that patient's symptomatic enough to come into the hospital. So one of the measures that I like to use, because it's not dependent upon the number of tests that are done in your community, is what the new hospital admission rates. So if you instituted a masking policy 2-3 weeks ago, you may not see any change for the first 10 to 14 days, but hopefully towards that 3rd week, you're going to begin to see hospital admissions decrease because you're decreasing community transmission. And that's what most communities have seen. That's exactly what the Houston community has seen. So I look at a couple of numbers. 1 is new hospital admissions. 2 is the percent number of positive tests. So you're pretty good in San Diego. If I read your data, it's about 5%. When we were at the worst of our second wave, where we had a positivity rate of around 23%, 23%, we're now down to less than 10%. So those are really good positive numbers. And as I said, my understanding of San Diego is that you're at about 5%. So you're in good shape. Now, what about what kind of masks to wear? So you may have heard about these gator masks. There's a lot of controversy about gator masks, but here's the thing. You should always wear a mask that's got at least 2-ply. It has to cover your nose and your mouth, so all above your nose to under your chin, okay? Surgical masks are great. The type 1 surgical masks are readily available. It's 3-ply paper. That's what I wear when I make rounds in the hospital. We all wear masks when we go into the hospital now. Our patients, if they can, wear masks, which really essentially has cut down almost all transmission in the hospital, which is great. So those are the kinds of 2-ply cloth or a surgical, type 1 surgical mask of the masks that are most effective. Single-ply, it's better than nothing, but it really doesn't block as much in terms of droplets, especially if you sneeze or you cough. Now, what about this issue of masks versus personal freedom? I think this is kind of kind of silly, and of course the anti-maskers is like they're out the anti-vaccine people. I think, as I've already told you, there's incredibly strong evidence that masks work. And you've probably heard the figure that if we continue to have a universal masking policy from this moment on, we probably can save 30 or 40,000 deaths by the end of the year. So that 200,000 number that some people are worst case scenario, I'm hopeful is certainly going to be less. But my question to you is, if you can't go out, you can't go to work, your kids can't go to school, I can't see my grandchildren because our community rates are too high, how is that freedom? Tell me, how is that freedom? I think wearing a mask is a sign of respect for your neighbors and your fellow citizens. I really think it's that simple. Now, there may be a few communities out there in the rural areas, although they're beginning to catch up, where you may not have any transmission. That's always a possibility. But I think, and I'll come at the end about my recommendations, how we live with this virus. I think masking is the new way in which we're going to be able to live with this mask. Now, I want to talk a little bit about children. I mean, many of you may be parents out there and you're wondering, are schools ever going to open? Or if you have a school like you have at the J or a private school. And so what's the risk for children? Well, let me give you a couple of facts that may or may not surprise you. You might be surprised that COVID kills very, very few children. And influenza, as an example, is much higher. So I'll give you an idea. If you have a child that's 1 to 4 years of age, the risk of dying from that is close to 0. Okay, where it may be around 30 plus. So if you look at influenza in children, about 200 people died last year from influenza. Less than 40 died of COVID, just to give you an idea. Now, as you get up into your older teenagers, like 15 or 16, then the rate begins to go up. And then COVID becomes a little bit more of a risk than influenza. But if you have someone going to elementary school, someone going to pre-K, up to about age 9 or 10. That seems to be the inflection point. Influenza is more of a risk to your child than COVID is, which gets me to another one of my things is that I think influenza vaccines are going to be really, really important this winter, because if influenza comes at the same time COVID's still circulating, you can understand the complexity of what we're up against. The other thing I want to say for all the schools and other organizations that I've worked with, safety guidelines are non-negotiable. There are safe ways to open and unsafe ways. And again, schools should not open, number one, unless you have some control of community spread and you've implemented the mitigation recommendations to open safely. And I'll get into that in just a moment. You probably have heard about that high school in Georgia that opened that had to close. If you've seen that report, let me tell you how they opened. They did not require the students to wear a mask, and they didn't prevent crowding like in the hallways of that school. That's not opening safely. Same thing happened in Israel. Israel thought they had the COVID-19 licked, and they opened schools, didn't mandate masks, didn't mandate social distancing. Once again, they had to retract and start all over again. Denmark, on the other hand, opened up schools, I think middle of March. They were on a downward trend, but they were still having a fair amount of community spread, but they implemented things very, very well, and they continued to see rates go down, and they were able to safely open the school. So it really depends upon whether or not you can implement and execute those proven mitigation things I'll talk about in a while to open safely. Now, according to just to give you an idea, the recent CDC reports that children make up about 22–23% of the population, but represent less than 10% of COVID cases, less than 3% of hospitalizations, and less than 1% of deaths. You probably have also heard, as I've already mentioned, that children age 10 or less may be a little less likely to get infected and transmit the disease. Unlike influenza, where children are often the vectors that transmit it to their families, this looks like it's just about the opposite. About 10% of children are actually the index case for transmission in the household. That means the vast majority of them who infect children are actually the adults, okay? So that's just to kind of keep things in perspective. And you might also think about this, that many more children die of suicides, homicides, drownings, just to kind of put things in perspective. I am not, by the way, by any means saying that you should not have a respect for this virus, but I want to try to put all those reports you hear in proper perspective. There's a couple of really nice studies on transmission in children that, again, as I mentioned, basically say the same thing, that young children are less likely to transmit and get infected, but they can get infected, by the way. I want to be clear, but they're less likely to get infected, and more importantly, they're less likely to spread it. Now, what about the mitigation strategies, which I've spoken about? So I divided up into three categories. One is what I call healthy classrooms. And again, you're in San Diego, which gives you a great advantage. One, everybody's got to wear masks, okay? If you're in the outdoor spaces and you can maintain social distancing, it's probably okay to give people mask breaks if they're outside and they can social distancing. If they're going to start to congregate or get within that 6 feet sphere and they want to talk closer to a friend or a teacher, then you should put your mask back on. You've got to wash your hands frequently. There's no question about that. You want to have multiple hand sanitizer stations all throughout your community, at the J, at the schools. Make it easy for people to do the right thing by frequently washing their hands. You want to maintain that physical distancing I already mentioned. You can do that by using your outdoor spaces or your big spaces indoors. Very, very important. You can sometimes put up barriers between desks like plexiglass, which some people have done very, very nicely. You may need to cut down on class size in order to be able to do that. And you want to make sure the classes stay in pods, especially the younger children, so they don't mix with other ages and other pods. And that works out well for a couple of reasons. First of all, it may cut down on transmission, But the second thing is if one teacher or one student gets infected and there has been exposure, you only have to close down that pod, only that one pod, as opposed to the whole school. So you may have seen things. Second, next thing under the healthy thing, you want to disinfect objects between users, and especially those high-touch areas within your classroom or in your spaces. So that's healthy classrooms. What about healthy buildings? I've already mentioned the importance of ventilation. So improving outdoor air circulation is really great. If you have a filtration system within your building, try to see whether or not you can upgrade your filters to what we call a MERS 13 or 14, which is more of a medical grade filter. I mentioned about plexiglass barriers. If you can install these no contact devices like the old water fountains, probably not a good idea. Probably want to have people bringing their own water bottles and have them refilled in a touchless environment if that's possible. And you also want to make sure you improve bathroom hygiene. It sounds like a silly thing, but you want to make sure the bathrooms don't get overcrowded. So you may have to limit the numbers, put in barriers between sinks, et cetera. And then the last thing about the mitigation strategies is healthy schedules. Do you need to stagger school arrivals and departure times based on class size? What about class transition? Can you stagger them, but can you have one-ways on different areas of the hallway? You don't want everyone converging, so you want to have good flow. And in many of the schools, we've recommended, in fact, that you eliminate lockers. That's where kids congregate, is going to their locker. So you have to have them have backpacks and make sure they have what they need to go to their next class. You may want to have separate entrances and exits, again, just to keep the flow so people are not constantly running into each other, but flowing one direction. And you want to mark lanes to encourage social distancing and directions. And also in some areas, you may even want to put on the floor, if people are lining up to do things, what it is 6 feet, so they know that they're supposed to keep their distance. You've probably seen that when you go to the grocery store, the pharmacy, where if you're waiting to check out, you'll see these little circles that represent 6 feet apart. Again, use your classrooms and other large spaces for lunch times. Obviously, lunchtime is time that obviously students have to take their masks on. So utilize your open spaces so they can maintain the distance. Also, the cafeteria kind of style is probably not going to work right now, and usually packaged or boxed lunches, if they get lunch at school, is the better way to go. That's really the important stuff in terms of the mitigation strategies that schools can take. The sad part is, and I'm sure it's the same way in San Diego as it is in Houston, that some of these mitigation steps, which I think are important if we're going to open our schools safely so that we can reduce the transmission of disease within the schools to as low a number as possible. I'm not here to tell you it's zero risk, but I am to tell you that if you do it safely, you can reduce the risk very, very low. And that's what we're looking for, is to get it as low as we possibly can. The problem with public schools, they may not have the resources to do all the mitigation things that I just mentioned. They may have to literally stagger schedules where not everybody can come to school every day because they just don't have the space, and the classrooms are too crowded. And you can see the challenges. And again, that increases the disparities of the lower socioeconomic groups. So I'm going to end by my last thing. I remember I told you the thing is living with COVID. I'm going to give you 5 ways to live with this virus. I've already mentioned some of them. One is universal masking. I think that's something for the future. You know, the Asians do this beautifully. It's a tremendous change in culture for us to do this. I know I wear a mask when I make rounds now the whole time. When I lecture and I make rounds with the residents and fellows, I speak through a mask. I don't have any problem doing that. Most people don't. So it's easy to be done. The most important thing is you find a mask that's comfortable. Okay, it's comfortable and at least 2-ply or is a surgical mask. That's important. Second is to avoid crowds. I'm sure you've had the same thing in San Diego, but I know what happened Memorial Day here in Texas. The beaches got flooded. The bars, as you know, have had to be shut down, as I know it has been in California. Places where people can congregate. you need to avoid crowds. And as you know, as we come up to the high holidays, I'm sure it's the same in San Diego, all of our larger congregations are going to be live streaming the high holidays because we're not going to get thousands of people crowded into one space. So avoid crowds. Social distance, 6 feet apart, wearing masks whenever you you cannot social distance, avoid crowds, and even small gatherings can potentially be at risk of maintaining social distancing. Anybody outside your immediate family unit, so you can look at circles, the more and more you get outside your family units, the greater the potential risk that someone in that environment may have COVID that can transmit it to you. So that's why it's so important to make sure that you maintain social distancing, especially in people outside your household or your very, very immediate family. If you can stay outdoors for most activity, that's great. I know that your Jay has moved some of the physical fitness thing outside. Again, you can do that in a place like San Diego because of your climate. And then the last one is, of course, hand hygiene. Wash your hair frequent and often. It's 20 seconds with soap and water. If you have those hand sanitizers, the waterless agent, make sure you put enough in your hand, about a quarter-size liquid, and rub it across all aspects of your hand. And you do it until it dries. One of the things I've seen people do is they put it in their hands, they rub it like this, and then they go like this. No, 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 no. You want to rub it until it's dry, not air dry it like this. Also, in terms of disinfecting the infrequently touched areas, don't wipe it off. Take it, spray it on, wipe it off, and let it dry on its own. The contact time is important. If you wipe it off, you lose that contact time. Okay, so that's all I want to say. I've kind of laid the foundation of the science. And also I will tell you the science may continue to evolve. And so what I'm telling you today may change over time, but I think we're in a much better place. The learning curve has been steep since March, and we've really learned a lot more about this virus. We now have some effective treatments, which I should mention. We have an antiviral named remdesivir. We now know that steroids like dexamethasone are important, and maybe convalescent plasma will have a role until we get the magic bullet. None of these are magic bullets. They're small incremental areas that help us in treatment and reduce mortality. But we're learning how to treat these people better. The mortality rates are coming down, but we still have a ways to go. So I'm going to quit now, and I guess we'll open it up for questions. Ryan?
Dr. Septimus, thank you so much. That was wonderful, and I was wishing that I had heard you speak about 5 months ago, when I was putting on my hazmat suit to grab the Amazon boxes from the porch.
Well, there are a lot of people, you mentioned that, a lot of people, they got these experimental system that says, lives on cardboard for almost 16, 18 hours. A lot of people were just leaving them out there and waiting a day before they touched them. You're right.
Is that something that we should still be doing, or have we disproved that?
Being able to find what we call viral RNA, okay, does not mean it's live virus. And as I mentioned before, the virus really rapidly degrades on surfaces. So even though you may be able to detect small amounts of the virus particles themselves, it doesn't mean it's virus particle, it's capable of transmission. So I think, if you want to be extra, extra careful, yes, but I think probably some of those precautions probably are not necessary. And again, after you touch things, of course, wash your hands.
Good to know. We got a lot of questions rolling in. We actually had a few questions that were sent in before. And the funny thing is they all touched upon the same thing, outdoor dining at restaurants. So let me pose an amalgam of those questions. Just a few people wrote in saying that they see people taking off their masks outside with other people to eat at restaurants. Even though it's outside, whether it's 2 people or 4 people or more, not 6 feet apart wearing masks seems to be a bad decision. How bad of a decision is this, and why does this continue to go on?
Well, let me say this: outside is safer than inside, so that's generally true. whether or not you're inside or outside, you still should be maintaining your social distancing. Okay? I think that's important for people to understand. Obviously, you can't wear a mask when you eat. The best way to do it is you have to reduce your capacity, unfortunately. I know this is tough for restaurants. You know, the bars are closed. We're asking them to reduce their capacity. So I know this, I'm being very sensitive to the economic impact. But I think we can balance it. So if you have less capacity, you can make sure people are at minimum 6 feet apart. What you do is you come in, and you might want to be even a little bit more than 6 feet, but minimum of 6 feet. You come in with your mask on, you sit down, and you take your mask off. Because remember, coming in, you're going to pass other people, right? So, and if you get out or get up to use the restroom, you put your mask back on, you go to the restroom, and you come back to your table, and then you sit down. So outside is safer than inside, but you want to make sure that things are well distanced from each other. They're not squeezing everybody in on every table. I think that's important. But if you can do that outside, it's safer than inside.
Okay. There's a question. We have a terrific swimming pool at the J, and a question was asked about transmission through lap swimming in a pool. Is that possible?
Probably highly unlikely. You know, your pool is chlorinated. It's not going to support the virus. And even right from the beginning, people said that swimming is fine. Now, where it gets to be tricky is when you come out of the pool, you don't want to congregate around the pool. So what I've advised a couple of health clubs that I've worked with is you have an appointment to swim so that you reduce the number of people that are obviously going to be in the pool. Okay, so you maintain some distancing. Obviously, you're not going to wear a mask when you're swimming. And then when you get out, even if there happen to be some chairs around the pool, that you space the chairs so you can maintain adequate social distancing. So you're going to have to sort of reduce the number of people that can be there. But swimming by itself, as long as you don't have people standing around in big crowds in the pool, is not a way in which it's going to be transmitted. The chlorine in the pool will not support the virus.
Thank you. All right. Recommendations for reuse of masks of each type.
Well, the paper or surgical masks are one-time use. You can wear them essentially all day unless they get torn or they get soiled. And those are very inexpensive, easy to change if you need to. If you're talking about the cloth mask, usually you can wear them all day, but we usually ask you to launder them if you wear them all day. And so you need to have more than one mask with you when you go out. If it's a cloth mask, if you're going to wear it all day. In terms of, we don't recommend the average public wear an N95 mask. That's something we use in the hospital. We take care of certain. You have to be fit tested. You have to make sure that you don't have any medical problems that may contraindicate. We do occasionally have methodologies in which we reuse N95 masks, but we don't recommend that the average public wear it. So cloth masks you can reuse and wash after you've worn them all day. And the paper surgical mask, you should dispose of at the end of the day, and they're very inexpensive.
Okay. Good question here, pretty specific. From Alan Lasnover, he says, my daughter is an elementary school principal who remains fearful of direct schooling for fear of contracting COVID, as well as other teachers and parents share those feelings. How do you justify in-person schooling and address those concerns?
What grade level is that?
Elementary school, somewhere.
Okay. Well, as I already mentioned, elementary school, the children of that age, as I already mentioned, the data seems, and I say this cautiously, that there's now multiple studies that show that those children are less likely to transmit. Okay, so I just put that out there. We also know, and this is not my area of expertise, but we also know the value of in-house learning, especially at children of that age. It's much more difficult for them to mature socially and mentally and socially remotely. So it's, by the American Academy of Pediatrics, Centers for Disease Control, the National Academy of Sciences, all advocate the importance of in-person schooling, especially in that age group. Now, I also believe that we should make it, I mentioned, open safely. So how do we do that? You do the mitigation that I just talked about. Any child now over age 2, the American Academy of Pediatrics just revised their guidance. And by the way, little children love wearing masks, by the way. You think, oh my goodness, child, they actually, some of them really like it. Now, under age 2 is dangerous, okay? So it's over age 2, they should be wearing masks. One of the things I already mentioned earlier, you should make sure whatever mask you use is comfortable. So you may have to experiment with the younger child as to which kind of mask is comfortable. Once they find a comfortable mask, I will tell you, they will wear it all day. It's just amazing. I think they do better than adults. We always project our own fears onto our children, but our children just do beautifully. So in an elementary school, okay, K to 5, those children are all old enough to wear masks. The teachers are going to wear, by the way, the teachers should be wearing surgical masks. Okay, and that's the recommendation. That if you're wearing a mask, your children are wearing masks, you try to maintain reasonable social distancing, you disinfect the high-touch areas in your environment, you do all the other mitigation things that I just mentioned, okay? And the community rate is under control, because that's another variable I think you have to take into account. Then I do think it's safe to open school. Again, I say safe if you do the mitigation things that will greatly reduce the risk of transmission, both to the students, and it's also equally important so that our teachers are safe. Also, some of our teachers are somewhat older. Some of them may have underlying medical problems, and they have to decide on their own. But we have to be careful, because we want to make sure our teachers are as safe as our children. And again, if you do these mitigation things correctly, the likelihood of transmission within the school is going to be very low. I'll tell you what the cases are going to come up. The cases are going to come up is a teacher or student tests positive. It turns out that positivity rate is not because of school transmission, it's because of the transmission in the community. We cannot control people's community behavior. We can control things within the school. And that's why I'm saying execution of the mitigation steps, I am hopeful, will make it safer to be at school than it is to go to the supermarket. So, but I would be less than honest if I told you I could assure everyone that the risk is zero. The risk is not zero. The risk, by the way, is not zero when your kids go to school that they may not contact the diarrheal disease. They may not contact influenza or another coronavirus which causes common colds. That happens, as you know, all the time. Of course, COVID is a new agent, and it's a little more contagious than flu. And in certain age groups, as I mentioned before, it may cause more harm than typical flu. But we can do these things if we do those mitigation strategies, which is universal masking, hand hygiene, social distancing, disinfect high-touch environments. We can do this and make the risk extremely low. And so that's my message to people who are thinking about going back to school, and also realizing the social and the emotional benefit of children coming back to in-person learning. That has to be balanced in the equation. So if you read the American Academy of Pediatrics statement, the CDC, the National Academy of Science, they all talk about the benefit of in-person schooling, but to open safely. That's the key.
You've mentioned the same safe practices a number of times, and it seems like there are people who get it, and then there are the others. Is there any hope, do you think, for converting the freedom fighters to get on board?
I hate to say this, but human factors and human behavior are pretty predictable. Okay, so think about seatbelts. How did we get everybody wearing seatbelts? Even though we knew seatbelts save lives, right? It became mandatory. How did we get our pediatric immunization rates up? We mandated it for children to go to school. And as you can see, when states become lax, and California is a great example, they got a little lax. They had these outbreaks, especially the big measles outbreak I mentioned. You started reducing or cutting out some of these really inappropriate exemptions, and you got your immunization rates back up. Masking is unfortunately falling into the same category. We have to, unfortunately, we try to appeal to the good nature of people, but you have these campaigns, the anti-vaccine folks, you know, and now we have these anti-maskers and these people that it interferes with my freedom, as I already mentioned. First of all, I think it's selfish if you don't wear a mask. And secondly, it doesn't give you more freedom. In fact, in the long run, it's probably going to give you less freedom, because it would be terrible if we had to lock the country back down. Just think about the economic and emotional. We've seen domestic violence up. We've seen opiate use go up. Alcohol use go up. People are unemployed. People who have chronic disease are not getting the medical attention they need. And we see increasing rates of heart attacks and deaths due to heart attacks. I mean, there are some very negative impacts beyond just the medical aspects of COVID that we need to consider. The other, and remember, immunization rates in children, what did that happen? They went down. They went down because people weren't going to the pediatrician because their offices were closed. So I think you got to consider all of that. You really need to be a good citizen. I think it's really patriotic to wear a mask. And I understand that our national leaders, I don't want to get political, but our national leaders have not been good role models. They're coming around. They're coming around, but you can see the mixed signals that we get from our politicians. Listen to the scientists. Listen to the Tony Fauci's of the world, okay? Listen to the science. That's why I titled this, Taking the Emotion and the Fear and the Politics Out of This Discussion. Let's talk about the science. And if we talk about the science, we'll do much, much better. And I know there's always going to be someone who's just going to refuse to do it. You see it all the time. People get thrown off airplanes because they refuse to wear a mask, et cetera, et cetera. We've got to do, I hate to say it, we're probably going to have to mandate it in most situations, in most areas of the country. When you're indoors, when you're outdoors, when you can't maintain 6 feet, we're going to have to unfortunately mandate that people wear masks for the foreseeable future. I think that's the way we live with this virus, and we can all get back to the new, I say the new norm, but we don't want to go back to a lockdown.
All right, the questions keep rolling in. I don't know, Dr. Septimus, if you're able to see the questions on your screen.
I probably can if I pull them up.
A couple here I can cluster together for you, though,
Okay.
from our own Fran Foreman and Deborah Pantoni. How long should the community rate be under control? I assume that means before we can resume. And then with that, there's a large number of clusters of infection in San Diego. So what should that number be to safely reopen? Really combine those two questions there for you.
Well, the cluster is a little bit more difficult to address. I can tell you what my measures are to safely open schools. I've already mentioned rates of hospitalization, because that's a hard number. It's about a 2 to 3 week lag, okay? Percent positivity rate. I'd like to see the rate definitely less than 10%. I like it to see it closer to 5%, but I'm also looking at trends. So if you start off really, really high, the way Houston was 2-3 weeks ago, we may not be quite there, but the curve is like this. It's the same kind of a curve that New York City experienced. So we're now at a positivity rate of 7 to 8%. We've seen significant decline in hospitalizations. That's a good sign. The other number that actually we're using here in Houston is, remember I talked about that reproductive number? And so we're looking at a reproductive number less than 1, meaning for everyone who gets infected, less than 1 person's getting infected as a secondary case. And our number in Houston now is less than 1. But that's a harder number to come by. And the other number that people looked are number of new cases per 100,000, okay? And again, depending by who you read, again, remember, there's no roadmap here. No one's ever done this before, so we're using what we think we know the best science. We look at modeling, which, as you know, has at times been inaccurate. And it looks like you certainly want to have your cases less than 100 per 100,000. I think you probably want to get it closer to 25 per 100,000. But I look at those trends. And if you see all those trends heading in that direction, and you've got good policies in place in your community, then I'm feeling comfortable that I have control in my community, not zero, okay? But I have control and it's safe to open the schools. So that's how I look at it. I would never have opened schools in Houston 2-3 weeks ago because our rate was way, way too high. I'm now cautiously optimistically in the next week or so, and there's a few schools that are going to open before Labor Day, or most of them are going to open after Labor Day. But a few of the private schools and parochial schools may open in about 10 days. I think we'll be there in Houston to safely open from a community rate standpoint. Now, the clusters are a little bit more difficult. And the questioner raises a very good question. There are some communities where the rates are much higher than other communities. In Houston, our Hispanic communities have been disproportionately hit. Obviously, you have a big Hispanic community in San Diego. So there was a very nice article in the New York Times contrasting a very big Hispanic community, what we call our Gulfton area, versus a more affluent area, which is the incorporated city here in Houston called the city of Bel Air. The rate of infection in the city of Bel Air is very, very low, yet the rate in this Hispanic community is much higher, with positivity rates of 25+%. Remember, they live in multi-generational homes, much more crowded. The people who work in those communities, they can't work remotely. They have to go out on the jobs. They're painters, they're carpenters, they're waiters, they work in supermarkets. They don't have the luxury that I have, that I can do some of my work remotely. And so they're out in the community and they're getting more exposed. So if you look at clusters in that community, it's going to be very different than clusters in other communities. And I think San Diego has the same thing. You can actually look what your rates are by zip codes. So that's a little bit trickier. So I kind of look more at the overall rate, but I would like to see some of those higher risk communities. I would like to see the percent positivity rates coming down in that community as well. But it's a different community, but I'd like to see the rates coming down across all socioeconomic groups, not just the affluent. Again, because the disproportionate number of cases are in the Hispanic community. If the community rates are coming down, the percent positivity is coming down, and the number of hospitalizations are coming down, I know there's less transmission in the Hispanic communities. And in fact, a disproportionate number of the patients that come into our facility are from that Gulfton area that I just mentioned. And we're seeing a clear decrease compared to what it was 2-3 weeks ago. So we know the rates are going down. So that's how I look at it. Again, I wish there was a set number that's written in stone, that's got, strong, public health backing, that we know that below this number, it's safe. We really don't know, but based on modeling and based on this public health principles, we think that's the guidance. Definitely reduction, decreased positivity rate, decreased hospital admissions. If all of them are going that way, you've got good mitigation policies in place, both in your schools, your work, and in your community, it's probably safe to prudently open. By the way, keep your bars closed. keep big gatherings. I mean, you got wonderful beaches out there and stuff. You got Labor Day coming up. We've got to do something to try to keep some of those large gatherings, and also to impress upon our young people. We're talking about older teenagers and young adults, that they're not invulnerable. They can get sick with this virus, and rarely, but it's tragically, they can die. So, and they can also transmit it to their parents and to their grandparents. So they need to make sure that they're not the vector, and they need to take responsibility as well.
Thank you. A couple more questions, if that's okay with you.
Yeah, we got a couple of minutes. Okay.
Okay. There's a question about household cleaners other than Lysol. It just makes me wonder, what does the Septimus household use to keep things clean?
Well, it turns out that almost any common, what we call EPA approved disinfectant, works against this virus. One of the nice things about it, I say nice things, one of the things that's easy about this virus, almost any common household cleaner kills it. Okay, whether it's Lysol, by the way, you can go out and buy bleach, okay? And you'll see on the directions, you can dilute that bleach every 1 or 2 days with water, 1 to 5, 1 to 10, and that's highly effective. Lysol is highly effective. Something called benzalkonium chloride is highly effective, but any EPA-approved disinfectant will kill this virus.
Okay, how about for those who try to be more environmentally friendly? Is now not the time, or is there a safe way?
Well, again, a lot of these disinfectants are very, very gentle on the environment.
Mm-hmm.
I mean, again, you can greatly dilute bleach. Now, I understand bleach on certain surfaces you may not want to use, but the active ingredient in Lysol, by the way, is not bleach. And there's other things called benzalkonium chloride, which are very good against this virus. So take a look at the ingredients and see what works best for you. I think in terms of being environment, if you can try to use something that's easy on the environment, that's great. And I think you can, but there are times now, again, because this virus is kind of wimpy in the environment, we're lucky. If it was, let's say, norovirus, by the way, which is a bad diarrhea stuff, cruise ships, that's not killed by the common disinfectant. You need something really strong like Clorox to kill it. But this virus, fortunately, is very easy to kill. So again, any mild EPA-approved disinfectant will work.
Okay. Question about air travel. Is there any such thing as safe air travel?
Well, I'm not even, well, first of all, it may not be even safe to get in your car and drive in San Diego, right? I will say the airlines, in all fairness, I think the airlines have really tried really, really hard. And they have learned how to clean their aircraft now. And they have these deionized cleaners that they can really do a very nice job of cleaning the aircraft. Most airlines on most flights are not filling their middle seats, and they're only going out with a certain capacity. They're all requiring you to wear masks. And by the way, the air filtration system in airlines is very good. It's been very good for years. They go through a HEPA filter, which is a hospital-grade filter. It filters out basically everything, including COVID, that might be in the air. So they've got good circulation. They now have good cleaning processes in place. They're using universal masking. Okay, they're trying to practice some level of social distancing. So I think it's relatively safe, much safer now to fly than it was before. So if you're thinking about driving someplace, as an example, let's say it's a 2 to 3 day drive, you have to think about where you're going to stop, where you're going to eat. Does the hotel chain you stay at have a good policy in place? And by the big ones, by the Hiltons and the Marriotts, they've got good policies in place, as an example, but you have to worry about that. Using restrooms on the, you know how some of the restrooms are along the road. So there are risks of doing that as well. So I think you have to pick what's best for you, and sometimes driving long distances is something that you don't want to do. But I do think it's relatively safe to fly. But again, like anything else in life, the risk may not be zero, but it's much safer now than it was before people got smart about how to protect themselves against this virus.
Okay. A final question for you, something I hadn't heard until just now. The rest of the world shares a distance of 3 feet as safe space, safe distancing, and with us using 6 feet. Can you comment on that? Is it?
Now, where did 3 feet come from? I'm sorry.
One of our attendees shared that the rest of the world uses 3 feet as a safe social distance for avoiding COVID.
Well, most actually use 2 meters or 6 feet. Okay, there is a study out that involves household contacts that does state, and if you see the American Academy of Pediatrics, they also say 3 to 6 feet, by the way. But in that household contact, those individuals that were within 3 feet for a significant period of time were much more likely to get infected than if they were between 3 to 6 feet. So that's where that comes from, okay? I think 6 feet is safer. 3 feet is probably pushing it a little bit, so I like to err on the side of safety. So 6 feet is preferable. Remember what I also said, sometimes these things can be transmitted more by the small aerosol, especially if you're in a crowded place with poor ventilation. So I want you to think about all that. But yeah, the person who said 3 feet, it's based on some of those studies, but still within 6 feet increases your risk. It really goes up if you're within 3 feet. So I think that's where people, but I don't know of any group, including the World Health Organization, that says 3 feet is okay.
Okay. All right, we can wrap things up there. Dr. Septimus, thank you very much for spending your time with us. I know everybody enjoyed this and plenty of questions. We could probably be here all night long.
Well, I hope it was meaningful, and I hope that, just to be fair, there's still some things we don't know, but we've learned a whole lot in the last 3 months. And I hope that with common sense and execution of appropriate policy, we can learn to live with this virus. We can go on with our lives in this new norm. And it's going to take all of us to be responsible to do that. And I think we can. And I hope that the news media doesn't scare you too much.
No, this was great. Thank you very much. And for those who were with us at the beginning, you might have noticed there was a slide with today's trivia question asking, in what year did the JCC movement begin in the United States? We're going to throw that up there for everybody right now. Feel free to answer on your way out. And if you don't get the answer, if you don't stick around for the answer, you will get it in our post-event email that goes out in the coming days. And I'll give you one hint. The first JCC began in my hometown of Baltimore, Maryland. So that's what I learned today. In addition to many things about COVID and staying safe and protecting ourselves and our friends and neighbors and communities. So Dr. Septimus, once again, thank you very much. It's great to be with you, and stay healthy, stay well. Thank you.
Good luck to all of you. Bye-bye.
Bye-bye.